Hello, my name is E. David Crawford. I'm a professor of urology at the University of California, San Diego, and editor-in-chief of Grand Rounds in Urology. I am pleased to welcome you to a Grand Rounds in Urology Presents educational program entitled Reinforcing Consistent Testosterone Suppression in ADT, Avoiding Escapes. In this program, we have gathered experts in the field of prostate cancer treatment, and our goal is to discuss androgen deprivation therapy and the role of triptorelin as a useful ADT option in treating men with prostate cancer. So a disclaimer is, this program is supported by Verity Pharmaceuticals. Joining me on the panel today are two good friends and international experts in prostate cancer. First, Dr. Scott Sellinger has been a partner in the past with Southeastern Urological Center, now Division of Advanced Urology Institute, and he's been with that since 1991. He went to the University of Florida in Gainesville, the medical school, and also completed his residency in Florida. Has been in Tallahassee for over 30 years, so he's a real Florida boy. He's also a leader, as witnessed by the fact he's been president of the Capital Medical Society, president of the Florida Urological Society, which, by the way, is an unbelievable meeting they hold every year in January. In 2018, he was president of the Southeast section of the American Urological Association. And another thing, he has been president of the American Association of Clinical Urologists. So we're so fortunate to have him with us. Also, we have Dr. Paul Sieber. Paul is currently president of Lancaster Urology in Pennsylvania, as well as medical director there for clinical trials. Any of you that see clinical trials and read the results know that Paul has been involved with that. He has got his medical degree from Indiana University. And did his urology and training at Hershey Medical Center at Penn State University. Again, he's been involved in clinical trials for 20 plus years, 200 studies. I really admire his enthusiasm for getting men on studies and women in GU cancers and making a difference. Also, one of the other things that Paul has done has been involved with the Capture database, and there are 150, 175 publications out there in the Capture database, and we thank him for that. So what we're going to do here is I'm going to review the journey, and then we're going to get into some of the current challenges, and we're going to evaluate some of the reasons for failure, and also talk about triptorelin and some of the studies that were done with that. So with that, I'm going to go ahead and begin the presentation. And I'm going to ask the faculty I have questions as we go along. But I guess before we begin, Scott, let me just ask you a question. What is the goal of ADT in about 2 or 3 words?
Lower testosterone.
That is 2 words. Great. So, Paul, let me ask you this. Are there any other goals of ADT or things you need to think about?
Keeping T low and not being negligent of monitoring what's going on with your patient, because it's more than just PSA, it's also T.
Okay, that's great. I think that's one of the things that we are getting off the track and forgetting, and we'll go through some of that as we go along, but it's pretty simple. ADT is to lower testosterone, keep it low, and not have it go up. All right, so we'll get started with the slideshow right here and our discussions. As I mentioned, the title of this presentation is Reinforcing Consistent Testosterone Suppression in ADT, Avoiding Escapes. So I asked this question, and I'm sure both of our panel members will agree, are all methods of ADT similar? And the answer is no. This is a long history of ADT. It actually goes way back to the 1700s, but I want to focus on one thing right here. And this is Andrew Shalley and his partner, who in the early 70s synthesized it, looked at GnRH and developed the first decapeptide, which was triptorelin. And we'll come back to that in a few minutes. We've come a long way since then. Hormonal therapy, we have a lot of options. I would guess, Scott, what do you think? That probably the top two are LHRH agonist and maybe to some degree LHRH antagonist?
Absolutely. So that's pretty much what most practicing urologists and oncologists are using right now to lower testosterone.
Paul, I know you've done a lot of work going way back with anti-androgens. What are your thoughts about anti-androgens at this point in a second or two?
I'd say the first generation anti-androgens are pretty dead. Used for, at least for us, for blocking flare, but after a 30-day run, they disappear. So I would say, to me, the first generation anti-androgens are non-existent. The second generation are in a different light than the first generation, which was basically just to combine with standard LHRH agonists.
Mm-hmm. Okay. So we know the sources of androgens. I used to think, well, it was the testes, and then along came the adrenal gland. And maybe that's where I disagree with you a little bit, is that some of the thoughts were with the first generation anti-androgens and Labrie to block the adrenal glands. And now we also know the tumor does it. So we've got three things we have to work on here to lower testosterone. As Scott said, that's our goal. Well, orchiectomy, we could spend some time talking about that. It's called the gold standard. People don't do it anymore. Actually, some studies show that may be one of the worst ways to treat it because of high FSH levels. Estrogens, estrogens really are a great way to treat prostate cancer because the side effects from ADT that we see are hot flashes and osteoporosis and all these other things, at least some of them. And that's due to lack of estrogens. Yet estrogens have that cardiovascular risk issue and also gynecomastia. Anti-androgen monotherapy is, as Paul said, is first, second, and third generation. But I know, Paul, you've done a lot of work with monotherapy with the bicalutamide studies and that. This is a real problem, and it's gynecomastia when you use anti-androgens alone. Any comment?
Oh, at least in the US, and if you look at those original monotherapy studies, compared to the Europeans, it was a major problem. Like 80% of patients had some degree of either breast tenderness or swelling or both. And it's a real problem that's takes a fair amount of effort to control. And then you worry about how those effects may affect your cancer outcome when you're trying to treat one end and you got a hole over here that you're putting your finger in the dike to stop that one.
So, Paul, we're probably going to be using, I call them the third generation anti-androgens now, apalutamide, enzalutamide, darolutamide monotherapies. You think that's going to be a problem, gynecomastia, with them?
Yes.
Okay. Thank you. So, monotherapy. As I said, I think one of the best ways to treat would be anti-androgen works. This was a first generation or second generation when bicalutamide studied against castration. It was close, but no cigar. If you look at LHRH agonists, there was a study that Mark Garnick did a long time ago, Leuprolide Study Group, published in '84. Look at this. They had 199 patients in this study right here. And this was a study that was published in New England Journal of Medicine that resulted in the approval of daily subcutaneous Leuprolide. Remember, it started that way. We put an anti-androgen with it, flutamide, some 4 or 5 years later or so, and published this article that showed that you can improve survival rate by 6 months by adding an anti-androgen to the LHRH compound. So here's where we are in 2022. We have all these different things to choose from, but by and large, what really works are these depots right here. There was a 12-month, it's still around, but that never caught on. It was maybe too long. This is another important milestone. Asking men, what would you rather have, orchiectomy or having an LHRH analog? And 87% said, give me that. This is the guy we owe this to, Dr. Shalley. This is a picture of us at the 30th anniversary of LHRH agonists in Budapest not too long ago. And he was the one that really developed this and developed triptorelin. We know that there are some issues and possible side effects with LHRH, including flare, which we're all familiar with. And then you see that, but also something called microsurges. And this is when you give an injection and maybe it's 3 months, 4 months or whatever. And because you're not completely suppressed, you get these little flares occur. And then there are always men that escape, and no LHRH agonist 100% or antagonist. And there's many reasons. We give the same dose to a 300-pound man that we give to a 100-pound man. And there are antibodies and other things that happen. So we're sort of in a dilemma right now. We know that orchiectomy, bilateral orchiectomy, you get less than 20. And many organizations, including the EAU and others, say, yeah, less than 20. The NCCN did a flip. At first they said less than 20, and now they say less than 50. But I think we all pretty much agree that less than 20 nanograms per deciliter is important to achieve. And again, I mentioned this, these are the testosterone levels in men with bilateral orchiectomy, and it's not less than 50, it's less than 20. Do they really matter? Do escapes really matter? Well, there is mounting evidence that it does. And I'm going to turn it over to Scott Sellinger right now to jump in and take us through the next area of this discussion. Scott?
Thanks, Dave. So there is mounting evidence that supports a definition of less than 20. And some of these trials we'll see are retrospective, some are prospective. But the point is that and a lot of this is not even new information. Some of it goes back all the way into 2007 and beyond. So we'll highlight on some of these trials here in just a second. This is Dr. Marotti, Dr. Crawford, Dr. Pericchino. And I think I was actually at that meeting too, but I think I was the busboy at the table when they had dinner. But there they are. They look pretty good. They look pretty good. So the testosterone escapes occur frequently during LHRH agonist therapy. And if you look at a definition of over 50 as an escape, you're going to see that in about 0.25% of the patients. And if you bring it down to a level of 20 to 50, it's about 1/3 of the patients. And I think that the clinical relevance here is that you commonly hear in offices around the country that it doesn't really make that much difference if I am a little bit late with my dosing on my LHRH drugs. And I think that one of our points today is it really does make a difference, and we want to try to keep the timing as close to accurate as possible. When you look at survival free of androgen independent progression, or basically looking at time to castrate resistance, if you look at group 1, which is the group that stays under 20, and this is from the Marotti data from 2007, this is a retrospective analysis, you can see that the group 1 clearly has the longest time to castrate resistance. And when we want to prevent adverse events in advanced prostate cancer, the first thing we want to do is prolong that time to castrate resistance. Castrate resistance is bad. Castrate sensitivity or androgen sensitivity, as long as we can keep that train going, that's what our goal is. And this is from Laurie Klotz from Canada. This is a prospective analysis looking at survival. And you want that hazard ratio to be as low as possible. And the group that shows the highest survival advantage is the group that has the consistent levels of testosterone that are under 20. We can compare the 6 trials that we are looking at here, 3 retrospective, 3 prospective, and a decent number of patients in these trials here. And the 2 parameters that we look at are the time to castrate resistance, or delaying disease, and improving survival. And in almost all of these are looking at a castration threshold of less than 20 with very favorable hazard ratios. This is from Dave's original article looking at basically large group practices, the impact of late LHRH hormone agonist dosing on testosterone suppression. So does it really matter? How good of a job do we do with adherence? The frequency of PSA testing, it's amazing. You asked that question at the beginning, Dave. You know, what is our real goal here? And we don't seem to have any problem testing for PSA, but getting people to test for testosterone sometimes is the hardest thing to do. And yet when we look at PSA testing, No problem. 83% routinely do it. 13% are looking at testosterone, and we need to really change that thinking process here to get people to understand that testosterone testing is important. The other point here is that these drugs were studied basically on 28-day months, and the reality is that a month in our country is either 30 days or 31 days, except for 1 month, sometimes February, that is 28 days, and this throws people off. But the proportion of late dosing is about 84% of dosing occurred later than scheduled in the pivotal trials. If you pool that across all 6 of the formulations of drugs with the LHRH drugs, you'll see that the pooled average was about 84% late when you base the definition on a 28-day month. If you base it on an extended month, then the pooled data is still showing about a 27% of the time the drugs are late. I'd like to ask Paul for a second. I mean, what is your experience in your office? You see a lot of patients in Lancaster that are on ADT. How close are you able to get to a true 28-day month?
Until we went to a formal ADT clinic, we were never close. And I think what's even amplified is, a 1 month, okay, we're only off by a couple of days, but when you get to 3-month formulations and 4-month formulations, we're getting farther and farther away. We're a week or 2 or 3 or 4 weeks late. So until we went to that regimented, you come back in 4 weeks, you come back exactly in 4 weeks, you come back exactly in 24 weeks, not 26 weeks, we were missing. And I'm like you, we're those oddballs that routinely measure testosterone because you see breakthroughs, and it happens.
Yeah, and so the implication here is that late dosing means testosterone levels that are higher than what you'd expect and higher than they should be. In fact, if you look at 27% versus 4% of the testosterone tests were over 50 nanograms per deciliter for late and early. So the lates were 27%, the early or on time were 4%. So you do a much better job of keeping testosterone less than 50 if you dose on time. And you can see that the pooled data there on the right that's being highlighted is at 27% are over 50, and that's really a conservative estimate of really true castration. If we look at testosterone less than 20, we're not even coming close to that. And here we are, the testosterone that's 20. And as I just mentioned, if you look at those late dosing there, the pooled results are over 43% of the time you're seeing a rise in the testosterone over 20. And if you believe the Verity data, if you believe the CLOTS data, which you should, that this is detrimental to patients as regards to overall survival and as regards to time to castrate resistance. So the conclusion of the study, we've already talked about that. I think that third bullet point is really where we want to highlight that 43% of testosterone tests showed T greater than 20 when dosing was late. 27% showed T greater than 50. And so these are very significant differences. So what makes a difference in these GnRH drugs? So the GnRH, the decapeptide that's at the top row there, this is the native decapeptide. This is what we have in our human bodies. And so what's different about the different formulations? And you look at triptorelin there, that number 6 position, it's a D-tryptophan as opposed to a glycine amino acid. And one of the things that does is it renders the decapeptide less likely to be cleaved. It's more durable and more indestructible, if you will. One of the other differences in the number 10 position there, you see that if that glycine amino acid is maintained, that as this decapeptide folds, that's its ability to bind to the receptor, and actually has more affinity to the receptor. And on the next slide here, you'll see the difference between the affinities of the receptor here in just a second. So as I mentioned here, you have the triptorelin. It's differs from the natural GnRH. It's got a longer half-life, and a lot of this is just because of those differences in the amino acid substitution. This next slide here shows that binding affinity, and you can see that the much higher binding affinity to the triptorelin as opposed to what you see with either leuprolide or the inherent LHRH that we have in our circulation. I think everybody understands the difference between agonists and antagonists, but this chart just shows a nice example of you get that rapid rise in testosterone immediately with an agonist, and then with the negative feedback on the hypothalamic pituitary axis, you see this precipitous drop to below 50 and ideally below 20. Compare that to the antagonist, which you see an immediate drop. You have that immediate blockade at the level of the anterior pituitary, and so decrease in LH and RH results in, particularly decrease in LH results in decrease in serum testosterone immediately. The end result is you see a T of less than 50, but it takes a while to get to that point. And we're very familiar with degarelix. This is the antagonist. The subcutaneous formulation of the antagonist is a 28-day formulation, and this works as we described. Relugolix is the new kid on the block. This is the oral daily antagonist, and it works similarly to degarelix. You see a immediate drop in testosterone, and you don't have to worry about a flare with this drug. So I'm going to turn it over to my good friend Paul Sieber, who's going to talk now about the history of triptorelin.
So I think this is something that most of us are unfamiliar with, at least in the States. So it actually goes back to this Dr. Shalley we talked about earlier, who got the Nobel Prize for this after first discovering GnRH by itself, and then subsequently designed the first drug to go after it, which is triptorelin, and designed to use in both men and women. And its attractiveness was it was very, very potent in terms of its activity, and certainly, as Scott talked about earlier, more potent than the other GnRH agonists, excuse me, LHRH agonists.
So thanks, Paul. This is a comment that Dr. Shalley made to me in a letter he sent earlier this year when we were talking about the history. And he said, we've synthesized triptorelin and developed it for use in male and female patients at TRELIN in the VA hospital in New Orleans. As many of you know, triptorelin is more potent in terms of LHRH, GnRH activity than other LHRH agonists. And we've already heard a little bit from Scott about the structure and why that might be. So turn it back over to you, Paul.
So it's also kind of interesting when you look at the history of the drug and its development and its use. I mean, it's approved in both the US and the EU, but it was registered same year that leuprolide in 1986. And it was actually the first ever. So it's a common among our European colleagues, maybe not so common amongst knowledge about it here in the US. These are two pivotal papers that looked specifically at differences between triptorelin and leuprolide and triptorelin and goserelin. And what we see in particular, we'll go back to picking on trying to get that testosterone as low as possible. And whether we're looking at just mean testosterone levels on the left, or if we look on the right, which I really like, looking at levels below 10 and just dramatic differences in terms of maintaining that percentage of patients with a very low testosterone below 10, striking differences. This is a little different way to present something similar in terms of looking at the two. If you look at the purple line, it's triptorelin, but it's a little bit similar to the leuprolide. But the difference is, if you look at the bar graph in terms of range, quite a broad range amongst leuprolide patients versus a relatively narrow bar in terms of looking at that triptorelin line, strikingly different. And again, shooting for that less than 20 number. So when you look at the overall achievement of castration at 29 days, we've got comparable readings and maintained out through the entire studies, which were 2 to 9 months in length. Again, just looking at mean serum testosterone concentration, just the bar graphs are just dramatically different in terms of what you're seeing amongst the comparative drugs here. If we look at escapes total, comparable size groups, 4 of 140 versus 11 of 144 during that 2 to 9 month time frame. So again, looking back at where we stand in terms of triptorelin, whether we're looking at a 1 month formulation or a 3 month formulation, similar kind of numbers, maintaining that very low mean testosterone below the barrier of 20 versus 50, which is the FDA requirement. And again, looking at the same story, suppression of the 3-month depot throughout the entire time frame, keeping it that magic number below 20. So if we look at the formulations of triptorelin currently on the market, whether it's a 1-month, a 3-month, or a 6-month depot, or as Scott mentioned earlier, not really 6 months, but 24 weeks, 12 weeks, and 4 weeks, maintaining that castrate rate throughout, highly successful in the 95% plus range, almost across the board. And as you expect, when we see the 3 different products looking at testosterone suppression, what should follow, ideally, should be PSA suppression and similar kind of outcomes, whether we're using a 4-week, a 3-month, or 12-week, or 24-week, 6-month depot.
Thank you. Those were great presentation, guys. And I sort of sit back and think, where's triptorelin been for the last few years? And it was coming on pretty strong a few years ago, and the pause button was hit, and now we can actually look at some of the potential advantages of it. But let's just talk about here as we finish up the key take-home messages. And I don't know, Scott, why don't you tackle a couple of these?
Yeah.
What do you think the big ones are here when ADT considerations? We know that ADT is a foundation you build on. It's the bottom floor here. You want it strong. What's some of the other things you think about here in ADT considerations?
Yeah, I mean, I think that your point about ADT as being the foundation for therapy, this can't be overstated. Every other therapy that we have, particularly in advanced prostate cancer, requires the continuation of androgen deprivation therapy. As we sit here right now in 2021, soon to be 2022, everything else that we do, all of our androgen receptor inhibitor pathway inhibitors, our immunotherapies, all of our radiopharmaceuticals, our PARP inhibitors, everything requires that we stay on androgen deprivation therapy. So it's here to stay. It's not going anywhere. And I think that, yeah.
Sorry.
Well, it's interesting too, Dave. I wonder if your original paper on flutamide would have shown a difference if you had instead used triptorelin. Because all those papers that look at breakthroughs are always commenting on, yes, if you have a breakthrough, there seems to be a need for you to take that anti-androgen. And I wonder if you wouldn't have been successful if you'd used a different agent.
Yeah, I don't know, but we do know that the whole goal here is to get T down and keep it down. And I think we haven't been successful. That the paper that we just published, about 84% of the time we're not giving it on time is important, these escapes. And we are, what's the goal here? What as Scott said, lower T. That's the goal with all the new drugs too that we have out there. The 1720 lyase inhibitors, the 3rd generation anti-androgens, is to lower the drugs. And we've got to be able to rely on our administration on time and drugs to do this. And I think that we will, let's see what happens. What else here, Scott, on this take-home message to the audience need to think about here?
Yeah, I think the timing of the drugs is super important. I think that most urologists and most oncologists that prescribe ADT don't really understand the implications of flares and the implications of breakthrough rises in testosterone, and that it does make a difference in overall survival and time to castrate resistance. I think that they need better education on that and better understanding of that. And I think people will do a better job knowing that of staying on schedule with the drugs to avoid those surges. And I think that intermittent therapy is an interesting concept. I think how much we're intentionally allowing testosterone at that point to go up, and how does that play into all this? I think
Right.
that's a very interesting question. And I think certainly patients that have defined metastatic disease, it would worry me a lot to do that, but maybe patients that are still just in the biochemical recurrent stage, without defined metastasis, how safe is it for them? So these are questions that I think still remain unanswered.
Paul, any comments?
I think
I think
Scott,
one of the things here is monitoring is critical. What are your thoughts about that? I think we're not doing a good job.
I was going to hop on
PSA.
that because I think that's exactly right. I mean, I think Scott said these patients are more complex. I mean, I think whether you're starting off by day one, when you're picking your agent to use, and day two, are you monitoring them carefully? And then day three, hey, how about all the other stuff like their BMD? How about their cardiovascular risks? Are you paying attention? And day four is going to be, what are you doing about genomics? Because that's coming around the corner. So I think monitoring these patients is a lot more complex than just give them a 6-month shot and let them walk out the door. You've done them a disservice by not optimizing what's going to happen over the near future.
I think ADT administration is shared care anymore with a lot of the folks around you, including your nurses, the cardiologists, even internists. When you look at this management of patients with ADT and what we do to them in the way of altering their lipids or glucose, not stressing exercise, diet, all these other things are important. And again, we could spend hours talking about that, but it's just, I think you just said it. You just don't give an injection and walk away. You have to work with the patients on a lot of different things. And that comes to monitoring and confirming, as we've said, PSA and testosterone, monitor for adverse events, compliance, feedback, shared care. That's all the other things. So I think we're coming to the end of this discussion. And Paul, any closing remarks you want to make?
I think you hit the nail on the head when you said it's a complex process that's going to require us to think a little differently, because there are a lot of new facts that have come to life that we have to pay attention to that historically, I think as urologists, we did not.
Scott?
Yeah, so the goal is to lower testosterone. So let's use the tools in our toolbox to achieve that to the highest degree, get your patient's testosterone to the lowest level possible, and hopefully you'll have the best outcomes.
Thank you. And I think that, as we said in the beginning, are all ADTs created equal? And the answer is no. And it's a foundation we use. There are great ADTs out there, and there are other escapes and things that occur. We let things fall through the cracks, and there's evidence that it does have an impact on progression and survival. So again, I want to thank you all for participating in this discussion of triptorelin, and we will have some more discussions in the future. Thank you.